Good afternoon, everyone. I am speaking on orbital trauma. I will just go through a basic format what to do in cases of orbital trauma. Generally, we encounter orbital trauma in cases of road traffic accidents. So we can have following things in the road traffic accidents like orbital fractures can be happening, hemorrhage, foreign body, emphysema, and luxation. We will dealing with one by one, although each can associated with each other also. So first of the thing, if any person present with a trauma, then first we have to divide the injured eye into two parts, whether it is the trauma of lid, whether it is intraocular trauma or extraorbital trauma is there. Orbital fractures, the most common we found in orbital trauma, where it can be associated with orbital skeleton only, which can be pure or impure blowout fracture. Whereas sometimes the severe gravity of injury is so high that the fracture of orbit is associated with maxillary fracture, NOE fractures or zygomatic fractures. So we have to divide initially evaluate all these things in cases of orbital fractures. So the most common fracture which we encounter is the blowout fracture, which is the most common injury in the eye, which can involve all the valves, but mostly the floor and middle wall is involved in most of the cases. It can be a pure fracture or an impure fracture. The pure fracture meaning thereby it is associated with orbital fracture, but orbital rim is intact. Whereas impure fracture, where wall of the orbit is fractured associated with orbital rim, which we term as an impure fracture. So effect of orbital fracture, we can get a herniation of orbital contact, or sometimes entrapment of inferior rectus is most common in inferior wall fracture, but other muscle is also get entrapped where fat entrapment is there. There may be damage of intraorbital nerve, or maybe there is dissection of orbital nerve or optic nerve also. So what are the clinical features they present? They can be present as diplopia, intraorbital numbness, periocular ecchymosis, or in ophthalmos or hypoglossa, or orbital emphysema is also observed in some cases. So what is a trapdoor? There is one interesting case, that is trapdoor fracture. Generally it occurs in children and young adults where the bone is not calcified, where they present to us that patient is presented, there is no sign and symptom in anterior segment, eye will be completely white, his vision will be normal, but when you examine carefully about the extraocular movement, then we find that there is a restriction of extraocular movement, and then we have to advise in such cases the MRI. Then we found that there is a teardrop sign is there. There is small content or inferior rectus muscle is entrapped in inferior floor fracture because of the wall is not very calcified, so that the fracture goes, and at the fracture time the rectus get entrapped in that place, and then the bone goes back to them. So there will be no anterior sign, no other signs of any trapdoor fracture or involvement, but there is only one thing where we find there is a restriction of movement, and this case has to be very much examined carefully. Whereas in investigation in any fractures, there previously we used to do plain X-rays. Then computerized tomography is the diagnostic of choice in acute cases. But the ideally we should have to do a magnetic resonance imaging with computerized tomographic cut, so that soft tissue injury will also be evaluated clearly with that of the bone fracture. Initial treatment of that fracture is use of nasal decongestant, broad spectrum antibiotics, and oral steroid to prevent fibrosis. Whereas in main surgical management, we have to wait and watch if there is no significant in ophthalmos, there is no marked hypoglossus or no entrapped muscle or tissue, and fracture where the orbital content is not very much prolapsed. So we can, in such cases, there is lack of diplopia. Such cases we can wait and watch. We cannot go immediately for the surgical management. We can observe the patient. If any signs develop, then we can go for any management, and we can manage to improve the local antibiotics and short course of oral steroid to counter the inflammation and infection. So what there are different guidelines based on which where we have to innovate. The guideline is for acute intervention if the patient present with diplopia with positive forced duction test, meaning thereby any muscle is getting entrapped in there. There is in ophthalmos with 2 that is cosmetically unacceptable, but this case can be encountered after 6 months, so that there may be every other things get healed. Large fractures which causes at least half of the orbital floor fracture, then we have to do a repair in such cases. So surgical management, so we have immediate intervention where diplopia with shows entrapped muscle or non-resolving oculocardiac reflex, where we have to intervene immediately. Otherwise, we can wait for few days to heal other parameters. Patient should be stabilized properly. After that, we can do a surgical management. It can be delayed in cases of blood fracture, which can plan surgery for 7 to 14 days after the trauma, or waiting time is allowed so that spontaneous improvement of edema will be there, resolution of swelling which we have faced difficult during the dissection, or then primary planning of the what should be the best surgical outcome for such cases. So surgical management, it can go from incision where previously we go through the skin incision, but mostly our incision is concise to subciliary or subconjunctival incision. Implants which we can use, different implants are available, that we can use autologous implants like clavarium, iliac crest or ribs, but most commonly we are using titanium mesh, which can be a 3D modified, or 3D implants, or some peak implants can be used for implanting the floor fracture depending upon the size and area of involvement. Newer implants like composite polyethylene implants, titanium mesh, or polydixon or glycolic acid implants are in use also. So these are the for orbital fractures. In orbital hemorrhage, it can be localized to subperiosteal or extracornal or intracolon within the orbital soft tissue or within the belly of extraocular muscle. Patient will present with pain, diplopia, decreased vision, ecchymosis, edema, elevated intraocular pressure. Maybe choroidal folds will be there. Blood luxation can be there because of this hemorrhage. It is a case of acute management if it causes optic nerve compression. So medical therapy, we can give you intravitreal mannitol, acetazolamide, steroid or tropical beta blockers to tackle this pressure effect of the to counter the pressure effect in the orbit, because orbit is a closed box. We can do a lateral cantholysis or canthotomy as an emergency procedure to relieve the pressure, which is a very simple procedure. And after that, we most of the cases in RTA, which is a infected fracture, there is a metallic or non-metallic foreign body we can encounter a lot of the time. So we have to judge about, take the proper history, whether it may be there, the foreign body may be, when we suspect there is a foreign body, it can be metallic or non-metallic. So if we suspect a metallic foreign body, then we have to be very careful in advising magnetic resonance imaging. In that case, CT scan is the investigation of choice. Otherwise, if patient give history that there may be a non-metallic organic body, so we have to go for the MRI scan to find any foreign body and deal simultaneously. So on managing, there is a treatment of choice. We have to give treatment prophylaxis. There is culture of the infected particles should be done to get the choice of antibiotic. Organic foreign body like wood and vegetables has to be removed, which can be easily accessible for anterior orbitotomy, whereas foreign body related complications like in the optic nerve compression, infection and extraocular muscle movement restriction should be taken care of in such cases. We often encounter a few cases of orbital emphysema. Yes, I will sum up here. Emphysema, where patient complains after sneezing, they get some blurring of vision, and mostly the MRI will show there will be some air pockets in the orbit. Such cases are uh, generally countered with management. Conservative management is done, and most of the cases resolve in 2 to 3 weeks of conservative treatment. Often, sometimes we get a globe luxation also, which causes severe anxiety to patient, and and it is an emergency process where we can easily reposition the globe, which using the C maneuver, which easily we can pull up the lid with the help of any forceps, or if it is not available, we can even use a safety pin as they have demonstrated, and pull up the upper lid and pressurize and put back the globe back into the orbit. So it can be managed like this, and finally temporary tassolaphy can be done. Thank you.
For presenting very well and accepting our request to present at last